Hello and welcome to Acadicus. My name is Dr. Nick Slayman. I'm a pediatric intensivist at the DuPont Hospital for Children in Wilmington, Delaware. In today's scenario, we're going to go over endotracheal intubation. And we've chosen the operating room where a patient is already anesthetized, sedated, and paralyzed. And we chose the operating room because rapidly acting sedatives and neuromuscular blocking agents are beyond the scope of this tutorial. So just assume that this patient has already been anesthetized, sedated, and paralyzed, and we'll start from there. So we want to start with some equipment introduction. So this is our laryngoscope. It happens to have a curved Macintosh blade with a barreled bevel on the end. This is designed to be placed in the vallecula above the epiglottis, and you lift in the direction of your thumb to help lift and peel the epiglottis up. There are also straight blades, which are referred to as Miller blades, and they're designed with a tip that you can kind of hook the end of the epiglottis and lift that up. We also have, of course, an endotracheal tube, and inside of it, we have a malleable stylet, so we can mold the tube to try to hopefully fit the angle of our patient and make sure that we can pass the tube through the vocal cords cleanly. This tube, as you'll notice, has a balloon on the end and a syringe reservoir here that you can use to fill that balloon with air. You want to check it before you put it in the patient. The worst thing is intubating a patient and then having a leaking balloon. While we're talking about checking our equipment, it's always good to open your laryngoscope and make sure the light on the end of the laryngoscope is fully lit so that it'll give you a good viewing situation so you can see the cords. We have a syringe again that we can use to fill with air and fill our balloon, and we have a little bit of lubrication. Some people like to lubricate the end of the endotracheal tube so that it passes easily into the patient's larynx. So what we want to do next is make sure that we have our patient in good position. It's important to have the head of the bed at a comfortable height for you so you're not bending and stooping to try to look into the airway, to have all your equipment placed on the table in a place where you can reach it, to have assistants that will be able to hand you things. And remember, every patient needs a difficult airway examination, so we want to pay attention to things like the size of their jaw, the flexibility of their neck. Do they have any missing teeth? Does their jaw open properly and easily? What's their Mallampati score? And to get the patient in good position, that gentle sniffing position that we need to have to make the larynx be maximally exposed when we use our laryngoscope, you may have to put a pillow under their shoulders. You may have to roll up a towel and get their head backwards into that gentle sniffing position. So then we take our bag and mask, we apply it over the nose and mouth. We're going to high flow, 100% oxygen breaths for 3 to 4 minutes. If the patient's still spontaneously breathing and hasn't been neuromuscularly blocked yet, you can apply that with CPAP. If they're already paralyzed, you will breathe for them and look for good chest rise. But with 3 to 4 minutes of 100% oxygen, you'll have a good oxygen reservoir. We want to make sure that our patient's fully monitored, so cardiac monitor, pulse ox, and blood pressure that's set to go off. And we want to have an end-tidal CO2 detector for after the procedure to confirm that the breathing tube is in position. So from here, now that we have our patient anesthetized, sedated, and paralyzed, we'll take our laryngoscope and hold it in our left hand. We're going to get good mouth opening with the scissor technique using our thumb and our index finger on the right hand. Get his mouth as wide open as possible, and then apply our laryngoscope. Again, lifting in the direction of the ceiling and exposing the vocal cords. Once the vocal cords are exposed, we're going to take our ET tube. We want to come in from the side of the mouth, and we often will have someone pull down the lip and give a little bit of retraction. We don't want to go down the middle and obstruct our view to the endotracheal to the vocal cords. So we'll now apply our ET tube. We'll remove our laryngoscope. Next, we'll fill our cuff with air. After we remove our stylet, fill the cuff. You can often palpate over the neck to feel that the balloon is full. We'll then apply our end-tidal CO2 detector, and we'll start to bag. Within 3 to 4 breaths, we hope to see the purple end-tidal CO2 detector go from purple to yellow. Yellow means yes. If it stays purple, purple is a problem. We'd like to see chest rise, equal and even. We can apply our stethoscope over the chest while we bag and have an assistant listen for equal breath sounds to assure that we're not in the right mainstem bronchus. We can look for vapor in the tubing as we bag. And finally, we can order a confirmatory chest x-ray